Hi everybody, a warm welcome to this webinar on resolving conflict with compassion. My name is Oscar Matthew. I'm a director of the Medical Mediation Foundation. I'm a lawyer by background, a mediator, and I run the Conflict with Colleagues and Patients courses for the MDU. I'm delighted to be joined today by Dr. Gaynor Whiter, who is an MDU medical legal advisor and impressively a dual qualified doctor and lawyer, and she teaches with me on a Managing Conflict with Patients course. I'm also joined by my colleague, Dr. Essie Menson, who is a consultant paediatrician, mediator, trainer, leadership coach, etc. So a small amount of admin before we start. We'd love this to be interactive. Please ask questions. There's a question mark on your panel in front of you. You can click that, you can put a question in. Ask these as we go, and we're going to look at them at the end of the session in the Q&A. You'll get attendance certificates, which are going to be sent out later in this week. And there's going to be a recording of this on the website afterwards. So Gaynor is going to start us off by setting the scene for the session, giving an MDU perspective, looking at conflicts that arise with both patients and with our colleagues in this context. And then Essie is going to take us through compassion, how it can help support us when dealing with conflict, and how channeling compassion in conflict situations can aid us in navigating them. And we're going to finish with that Q&A. And we'll try and look through as many of those questions as we can. So warm welcome, and over to Gaynor to get us started.
Hello everybody. Essie, would you mind putting on the first slide, please? Okay, so at the MDU, we are often asked to help our members, our doctors and clinicians, to help them when they have conflicting situations, both with patients and with colleagues. And there is a patient expectation, I think, now. Most patients think that the pandemic is over. And because of this, they feel that they've been extremely patient and they need their concerns to be addressed now. However, the access to services is impacted by the pandemic. There were already quite a few delays anyway, and now there are very long waiting times for routine referrals and cancelling and recancelling of elective surgery, and that leads to frustration but also increasing pain for patients, and their conditions may be worsening. There's also a real pent-up demand for services. There's no longer any clapping. Patients say that they have to seek care from A&E if they say they can't get GP timely care, and there are also delays in the other services, for example, ambulance delays, and it isn't uncommon for me to see accounts of patients who say they've had to wait 8 hours. One patient said they had to wait 3 hours when they were having a stroke, for example, and the "are you breathing" question seems to indicate sometimes that there doesn't need to be an emergency ambulance. That's what we're being told. There's also real media scrutiny of the changes to care delivery. For example, the rise in video and telephone calls is interpreted by some papers as happening at the expense of face-to-face discussions. It's clearly one of the things that has changed over the pandemic, but the face-to-face delivery is increasing, and also there are a number of other things which are occurring, such as e-consults are really taking over, and in fact there is unprecedented demands. So GPs are also being asked to provide notes for medical and non-medical issues. So for example, in the Daily Mail on the 10th of July in 2021, there was an article about GPs requiring councils requiring GPs to provide sick notes prior to permitting removal of seagull nests from outside patient homes. And I'm sure you'll be aware that there's a current proposal for GPs to prescribe money off energy bills, and that was in The Guardian in August of this year. So those sorts of things are really adding to the pressures that doctors have. And all of that leads to an overwhelming number of patient queries and a lack of continuity of care, because it won't necessarily be the case that a particular person can get to see a particular patient the whole of the time, because of the way that the appointments are scheduled and the need for routine or urgent appointments. And in the hospital setting, there are doctors who are providing advice to GPs, as well as seeing patients both face-to-face and via video consultation. So there is more and more work that is being done and being expected to be done. However, there are many more complaints that we're seeing now that doctors are inaccessible, or that due to the pandemic or otherwise, there's a delay in diagnosis, a failure to examine, or a failure to provide safe spaces in hospitals and surgeries. And you can't get it right. I've heard of one GP who said that patients wanted no masks, and another patient wanted to be in the specialised room for particularly vulnerable patients when they weren't particularly vulnerable. So you'll always have the opposite end of the spectrum, and it's very difficult to get it right or to make everyone happy all the time. So could I have the next slide, please? Okay, I think you're missing one slide. The feelings that the patients have, what do they feel? So they're frustrated, scared, and they may be in pain. They're worried that they need help, but they can't get it. They've waited weeks for an appointment and they're being rushed. There's only a short amount of time to discuss their concerns and explore the options. And we often see complaints from patients saying, well, I wanted to talk about this and that and the other, and hadn't been able to get an appointment, and I've been waiting for this for weeks and weeks and weeks, whether it's a hospital or a GP consultation, and actually I couldn't explore everything because there wasn't time to do it. And I don't know when I'm next going to see a doctor, because there aren't any appointments, and they've said they won't be able to see me, and I'm on a waiting list. And then the other thing that often comes up is that the doctor says things like, what can I help you with, and what would you like me to do? And the patient thinks, well, you're the doctor, you should know. And I think that's just a part of the communication, because it's the way that we're told to try and use open questions and open phrases, but sometimes it's interpreted as, well, you don't know what to do. You're the one that should know what to do. So that's from the patient's point of view, but from the doctor's point of view, they're seeing it as we see it as a routine appointment. We know that actually their symptoms don't seem to be very concerning, and there are many more patients who are waiting for much more urgent things, who do seriously need help and can't get it. And so that's a bit frustrating from our point of view. We've got insufficient time, we've got an increasing workload, and we're overwhelmed with patient queries. And that's set out quite clearly in the medical press. For example, I saw a Pulse article which said nearly half of GPs face unmanageable workload. Poll suggests that's again August this year, and saying that full-time GPs are really a thing of the past, because nobody can do the job full-time anymore because it's 12-hour days, and so a full-time GP's workload is too much. Then there's also the thought that once you've seen this particular patient, there's another 12 to see, and then you've got to go to the ward or do review of patient results, which means that you're leaving the workplace very late and you're already tired. So that is placing a great deal of strain underneath all of the patient consultations. So would you mind please putting on the next slide, please, Essay? So by the time the patient reaches you, they may already be upset. There can be sort of receptionist issues or secretarial issues, or there can be booking issues. And so it's important that those prior contacts with your administrative colleagues are constructive. The sort of computer says no sort of attitude. Oh, we don't have any appointments. No, sorry, it's not possible. No, you need to go to the pharmacist. No, sorry, there's a waiting list. It is really frustrating for patients. So try to put yourself in those patient shoes. So what's routine and obvious to you may not be routine or obvious to a patient. So when you're explaining something to a patient, just remember that it might not be as easy to understand as you think it is. And I often think of going to a car mechanic, for example, from my point of view, because when a car mechanic starts talking about alternators and carburetors and flywheels and clutches and the innermost detail of those, you know, I start switching off and don't understand what is going on. And I suspect that for some patients it can be the same thing. So just try to put yourself in their shoes. Do try to make time for yourself. I know that's a really difficult thing and it's a very trite thing to say, but actually just a quick break or a discussion, a chat with somebody else, a drink, getting yourself some food just might take the impetus out of the conflict or the frustrations that you're feeling and give you time just to take a step back. And do share the burden of the heart sink patient. There are heart sink patients in every sphere of medicine, and sometimes just getting to speak to others about them is a really good thing. So an MDT or sharing the burden with a colleague or the practice meetings, they can all help, and then you have a consensus of opinion and you feel more comfortable. So could we have the next slide, please? Conflict with colleagues. So there's also a huge increase in the conflict that we see with colleagues because of the systems in place. Often, so there are often patient safety issues that are mentioned to us. But also, you know, we're just coming out of COVID. There were very different reactions to COVID. Some doctors were personally very afraid and they would just work at home. Others weren't, and the willingness to practice acutely was very different depending on who the doctor is. So doctors are very vulnerable, weren't necessarily those who wanted to shield, so they were there in the workplace, and that was a source of a sort of concern. Whereas, you know, the vice versa position happened also, that, you know, those who weren't at all vulnerable felt very vulnerable and declined to come in, and there was a lot of resentment which was fostered. The backlogs were huge anyway, but now they're even more huge, and the working conditions are still disrupted. There are COVID wards still on hospitals. I know there's no routine COVID testing, but there's still quite a few COVID patients, and that affect. And if there's a sort of a peak, then that affects what is happening with the operation lists. The working conditions are still disrupted. There's a concern that care isn't safe and that it's not being addressed by seniors, but those seniors are in turn trying to deal with the financial and recruitment constraints and difficulties that they're facing. And so, you know, there are frustrations from each part of the workforce. It's never ending. Everybody's tired. Everybody's stressed. When is it going to end? So all of that leads to dysfunctional departments. There are allegations and counter allegations, and then you get factions developing with some doctors in one faction, some doctors and nurses in other factions, and that just creates more and more conflict. And some doctors and other clinicians also are being investigated. Their performance is being investigated. Their conduct is being investigated because the frustrations lead to shouting matches in some cases, or allegations that they are being obstructive. All of that leads to an increased staff sickness, but also compromised patient care, because the factions become more important than the care. Could I ask you to go to the last slide, essay? So the strategies here, they may seem quite obvious, but, you know, it's always important to encourage open discussion between colleagues. That might not be possible easily, and sometimes you can get independent and external mediators to mediate if the relationship is fractured. I think explaining the difficulties in meeting service provision is really important to those doctors who are clamouring for more. So seniors can provide more information, and those can be explored. Can jobs be changed? Can plans be slightly amended? If there's a working will to do things, things can improve. Most importantly, we need to acknowledge the stress of the workload. I think that just giving us more and more to do is not going to help, and we are being set up to fail. So the take-home message is to try to share and alleviate that burden, and to have the facility and the willingness to listen to make that happen. So that's my introduction, and I hope that was interesting and helpful.
Gaynor, thank you so much for that. Going to move on to Essie now to dig in a little bit further into compassion and how it can help. So Essie, over to you.
Thanks very much, Oscar. Now, those of you who have an interest in compassion may have come across this book that came out just before the pandemic, 2019. And the two authors, Precept and Mazzarelli, actually took on the task of reviewing all the literature on the role of compassion in healthcare provision. And they asked, I guess, what is a pretty pivotal question. Does compassion matter? Does it make a difference? If you're interested in this field, I commend this book to you. And this is a list of some of the outcomes that they summarized from the research available to us at that time. And it makes a huge difference, makes a vast difference to outcomes. That missed opportunities are costly in all sorts of ways. That being compassionate helps healthcare professionals too, and it is even an antidote to the burnout that so many are experiencing. And a very sort of powerful message at the end there, that a few seconds, 40 seconds of compassion can save a life. So this book was in relation to healthcare outcomes and the experience of healthcare professionals. What about when it comes to the arena and the really tricky area of conflict between ourselves and our colleagues, or ourselves and patients, as Gaynor has just summarized? Well, we think it's really helpful to start by unpicking some of the terminology and the processes that relate to empathy and empathy-related experiences. And this helpful sort of infographic perhaps summarizes it quite nicely. Empathy being that feeling of feeling for somebody, perhaps understanding what they've been through, perhaps because you've been there, or you can imagine what that might be like. The distinction from that in compassion is, has that empathy feeling, that feeling with, but also importantly, a desire to help. And we've given a reference at the bottom there, the role of empathy and compassion in conflict resolution, because it's a very accessible review article written by Olga Kemecki, who actually works in the School of Medicine in Geneva. And she has looked at the research and how compassion and empathy can help interpersonal relations and help in the resolution of conflict when it arises. And that's what we'll be talking about a little bit more. But when we think of the ingredients of compassion, we've talked about the empathy piece, the feeling with, we've talked about the additional component being moved to help. But importantly, and we think there's a third ingredient that's key, and that's borne out in some of the recent research in the last 5 to 10 years. And it's about entering into compassion from a space of wanting to help, but not assuming the sole responsibility to fix the problem. Why is that important? Because as health professionals, we're very much in the sphere of fixing things. People come to us with symptoms, with problems, and our role, our training has developed us to explore the problem, try and find an answer, and move on. When it comes to conflict, we have a particular drive to want to do that, because conflict often takes us to a very uncomfortable territory where there are all sorts of perhaps even identity issues, questions about how we've performed. There are strong emotions, perhaps uncomfortable emotions that fall into this arena. So we're particularly compelled to want to fix it and move on. However, we know that when people are engaged with in the realm of conflict without being able to be part of the discussion, and importantly, without having their perspective fully heard and acknowledged, and that can be a real barrier, and it can be a roadblock to being able to move on in conflict. So we list these 3 ingredients: feeling with, feeling a desire to help, but not assuming full or sole responsibility for solving the problem. That means we need to enter the arena of being in partnership, co-creating a space where we can explore the problem and try and find a way forward together. But what is compassion? What happens within us when we are asked to be in the realms of compassion? And there's some wonderful research and from a number of areas and bodies, both in the States and the US, in Europe and in the UK, looking at the physiology that happens when we're being compassionate. The research has been conducted with sort of professional compassioners, such as sort of monks and priests and healthcare professionals, but also lay people. And the evidence is pretty consistent that compassion isn't the warm, touchy, feely, comfortable space that people often describe it as, but it's a biphasic process, and it starts with that sympathetic adrenaline and cortisol-fueled response, that flight or flight response. And that is often pretty uncomfortable. We feel our heart racing, we feel sweaty, we feel tense, our voice quakes. That fight or flight response, and that also the tunnel vision that comes with it because it's driven by the limbic system, and that sort of disconnection with our ability to connect with our prefrontal cortex, to connect with our executive functions, with our wisdom and our thoughtfulness, that all comes first. Afterwards comes that parasympathetic response, the more calm, connecting and befriending response, which is more what we think of as being compassionate. So why is that important to know? Because if we find ourselves in that fight or flight space, we often get afraid, we feel unconfident about our ability to engage in that space. Whereas if we know that that's a natural part of the response and that the parasympathetic phase will follow, then we can stay in that space with a little bit more confidence. We also know from the research that if you blunt that initial sympathetic response with medication or whatever, you actually also blunt the capacity for someone to engage in that parasympathetic tend, befriend, connect, engage process. The transition, however, takes time. So our task is to be able to withstand, endure, stay in that discomfort. As you might say, become comfortable with the initial discomfort of being compassionate. So we remind ourselves that it's an unfolding process. It's one that we feel in our bodies, in our minds. So if we can allow time and space for it, then we're more able to harness the benefits it can bring. It's also important to recognize that compassion is just one of the possible responses to people's pain and suffering. Sometimes we feel overwhelmed by suffering. We might, perhaps in the times we're living in, many of us might be experiencing times of feeling quite some overwhelm with all the myriad of issues that are going on in the world at large and more close to home. We might want to withdraw. We might feel angry. We might feel resentful. We might start comparing one suffering with another person's suffering. We might find ourselves in judgment, and that in itself can be quite conflicting feeling and make us want to withdraw from the whole experience. Yet true compassion is born out of recognizing all of that, but still being willing to care, finding the courage to step into that space and engage with that person despite all of those conflicting emotions that we might be feeling. And importantly, have what's described rather tautologously as compassionate intention, a desire to be with, to want to help, to not take sole responsibility for solving the problem, to stay in that co-created space and try and find a way through, which isn't always easy. It can be particularly hard if you don't agree with the person, they're frankly wrong, they're being difficult to manage, their behavior is feeling very unacceptable to you, and you might be feeling compromised yourself by how the person might be engaging, what they're saying, what's going on around you. So it is also really important to recognize that compassion isn't a given. There are real barriers to compassion, and they often happen below our level of consciousness. What's been described is that we all unconsciously weigh up whether we can be compassionate in any given situation. We carry out a cost-benefit analysis. Are they like me? If somebody is like me, it's so far easier to be compassionate to them. Or if they're close to me, a friendship or a relative, a colleague might be easier to be compassionate with than another who seems a bit more distant. Then there's the comparisons and the judgments slip in. Do we feel this person deserves our compassion? Maybe from their behavior, perhaps we might think they brought their health problem or their condition on themselves. We might be feeling that they've acted inappropriately to ourselves or others. We might be judging them in that regard. Then there's the element of ourselves. Do I feel up to it? Do I feel resourced to be compassionate in this moment? Perhaps because of things going on in my personal life or other work-related challenges that I'm dealing with. A whole list of other things I've got to do. That constant sort of seemingly unwinnable challenge of time that we're often facing. And then there's the question, is this going to be really tough? Am I going to be able to keep my own emotions in check? And if I don't feel I can, am I going to withdraw and resist being compassionate because I'm not sure I'll be able to conduct myself in the way I feel I should? These barriers lead to assumptions and judgments which help buoy up the decisions that we make, and they slip in below our level of consciousness. So what we're saying here is compassion is helpful, compassion is an unfolding process, but there are barriers to it too. And if we can be aware of these barriers, it helps us to start to overcome them. You know, knowing is the first step to overcoming any of these sorts of processes. And in addition to that, those barriers are real. We're not wrong or bad for experiencing them. So if we can engage compassionately with ourselves and accept ourselves in a situation, that can in itself help us to be able to engage more compassionately with the situation that we're dealing with, especially when it's conflict, which takes us into a really tricky space emotionally and cognitively. So how do we do that? How do we take steps to expand our capacity for compassion, especially in the arena of conflict? Well, as with anything, with any change, there's that recognition that things need to start with ourselves, where we are, because of course, when we think about the circles of control in the world, we can only really control our things and ourselves and things very close to ourselves. So the first element that we can start with is developing, considering, thinking about our level of self-awareness. Checking in with our intentions when we go in to have a conversation. I certainly put my hand up to having had numerous conversations as a clinician where my intention was to get someone else to do essentially my bidding, to agree with me or to agree that I was right and go on with move forward with my plan. If I'm engaging in a conflict with that intention, that's unlikely to be helpful. So if I can check in with my intention and try and engage in the conversation and from a more listening space, a more collaborative, co-created, co-solving space, it's much more likely to be helpful. Also, my self-awareness extends to noticing my own internal state. Am I agitated? Am I angry? Am I feeling exhausted? Am I feeling empty? Am I in an internal state that's going to be conducive to this interaction that I'm going to be trying to resolve? Also, I can check in with my biases. What could be at play, consciously or often unconsciously, that might impede my ability to be in that reconciliation space with the other person? Especially if they're below my radar, then I can just run through the sorts of things that we're aware of, selection bias, the groupthink, all of those things that are at play when we're engaging in a situation where somebody's not agreeing with us and we're finding that challenging. The second element is self-compassion, that really important space of recognizing that conflict is tough territory. It's hard. Very few people like it and enjoy it or engage in it well. So to be kind to ourselves is a really important way forward to try and engage in conflict more productively and effectively. It's easy when you're in a conflict to get into the space of admonishing oneself. Oh, I didn't say the right thing, I did that wrong, somebody else might have done it better. None of those are helpful. What's needed much more productively is self-kindness, and also the catharsis that comes from knowing that we're not alone, that anyone else might be feeling as we might be feeling, finding it difficult, be feeling self-doubt, and be finding the whole situation emotionally charged and challenging. And in our self-compassion, we can try to be present, try to put aside all the other things on our to-do list, all the other challenges we're facing, to try and ground ourselves and be present in that moment so that we can engage more constructively with the other person, and we can find that it gets the best result for ourselves too. And then what's the third thread? The third thread is self-care. This is what we do outside the moment, that background caring for ourselves, that's so important. Developing a practice of noticing, naming and acknowledging how we feel in all sorts of situations. There's a wonderful body of science that shows that that is a powerful thing in itself, to notice and name, acknowledge what we're feeling. Secondly, to think, what do we need? Do we need a bit of rest? Do we need some fresh air? Do we need a colleague or a friend to talk to? Do we have needs that are well met, which can help us engage more productively? And then that underlying issue of nourishing ourselves nutritionally with food, but also nourishing ourselves with time out, green space, time with loved ones, time and spaces where we feel valued or we feel we're doing well, where things aren't so challenging. All really important, because in our brains we all have a reward center that needs to be stimulated, and if we don't spend enough time in those spaces, we find it much more difficult to deal with the difficult challenges that we can face. If we can be compassionate when we're dealing with conflict, we are the first recipients of our own compassion. It helps us to feel calm, to feel collected, to be willing to be collaborative. It helps us caretake the other person or the situation without jumping into that fix-it mode that we have a tendency towards. It helps us to be curious. What's the other person's perspective? How are they seeing things? What's their experience? What's their view? What is the impact of all of this on them? That curiosity space softens us so we can better engage and better hear. It helps us manage emotions, our own emotions, but also withstand perhaps what can be a torrent of emotions from the other person. And it helps us to listen deeply, to stay engaged, to be willing to help the other person feel heard. We'll touch on the importance of that shortly. All of this is underpinned by trusting that that feeling heard feeling in the other person is key to allowing ourselves to be in the platform where we're both willing to work together, co-create, and find a way forward together. And this is a quote from a colleague who had done the training that we deliver, and they said that they'd noticed that they picked up the early warning signs of conflict much earlier, but they actually didn't have to do much. They said, I listen more and I speak less, and I feel more confident that that's what's needed. very easy in conflict to feel that we've got to do. And the doing that's most powerful, and has been demonstrated to be so, is that listening space. And that often involves less speaking, silence, pauses, looks, acknowledgements that help the person feel that they are engaged in a joint venture with us. If we can be compassionate in conflict, it helps the other person too. And these are some quotes we've had from parents who've been engaged in conflict, but they could easily be transposed to some of the comments we've had from colleagues who have been engaged in conflict. I felt heard. I felt she cared about what I thought and why I thought it. I felt that he gave me time, even though he was crazy busy. I felt supported without being taken over, without being directed to do one thing or another. And this person said, you can tell when somebody's really listening. They let you have your say. They let you have time to think things through as you speak them aloud. Things that might be going round and round in your head. So compassion helps us, it helps the other person, it helps us both be willing to be in a platform where we can look at reconciliation, solving, and finding a way forward together. We use this image in our training because it's born out of a process called dialoguing that's used in imago therapy. It depicts conflict as two islands that look really very different on a stormy day, the storm of conflict. And the task here is for one person, ourselves, the health professional perhaps, to be willing to extend a bridge from our island to the other person's, to be willing to cross that bridge, sit down and listen to the other person describe their perspective, how they see things, what their island looks like. What we want to be doing is to be listening to understand. We know in conflict we have a tendency to listen critically, so we can challenge. What do I disagree with? What's wrong? What can I correct? What can I advise them better on? What can I tell them? And what's more productive is listening actively, demonstrating we're listening with the nods, the looks, the short noises, the not speaking. That helps the person feel listened to, and the deep listening to understand what their perspective is, recognizing that that is not the same as agreeing with them or acquiescing, certainly isn't being a doormat. It's helping them feel listened to. When we're able to do that, there's a greater chance that we can then invite the other person back across the bridge, effectively to our island. There's a greater chance that they'll respond positively if they themselves feel that they've been listened to. And then we can engage in describing our perspective and helping them understand how we see things. We may still disagree, but we're much more likely to be in the realm of being able to be collaborative and try and find a pathway forward that we can both be settled in, be it clinical, be it with colleagues. Know that this process can work in all sorts of different arenas. So there's something here about consciously choosing how we're going to listen. There are all sorts of different schemas for listening, and I don't think we often think about that when we think of listening. We can easily think of it as a single-threaded activity, but active listening, we've talked about passive listening, just that listening and saying nothing. That critical listening space that conflict often takes us to, where we see red, when we're just looking to see how we can win the conversation. More productive is that compassionate or empathic listening space, listening to understand, listening to help the other person feel heard, feel understood, even if we don't agree with them. That's the space we're trying to get into. So we're going to end with some concepts and precepts that might help us when it's challenging to help ourselves yield into a compassionate mindset. The first precept is really simple, to remember that especially when somebody's not communicating the way that we like or we're used to or find acceptable, to pass through our minds that it's very likely that the other person is communicating at their best in this moment. And if they could communicate better, they would. They may have all sorts of fears, emotions, anxieties going through them that is hampering their ability to communicate better. So what can we do? So we can respectfully inquire of them, of their motives, what their reasoning is, rather than judging the external behaviours and the positions that we're seeing, all the decisions that they're made. And when we inquire respectfully of another person, we show that compassion. They feel it and they are likely to respond in kind. Of course, nothing's guaranteed, but the more we can be in the mindset that the person is doing the best they can in that moment. So how can we help them to communicate with us in a way we can understand? That can be productive. And as we said before, we are the first recipient of our own compassion. So even if the other person is unable to do any better, we find ourselves calmer, more grounded, more able to engage. Precept 2 underlines the fact that conflict is hard, and it's okay for me and for the other person to have strong emotions and to show them. That can be a really settling and calming precept to run through our minds, and it helps us to develop the capacity to manage our own emotions and to talk about strong emotions, our own and the other person's. If we can help people name, recognize, acknowledge and identify what they're feeling and talk about them and go from there to talk about the impact of those emotions on them, we're in a collective space from which we're more likely to be able to move forward from. And then precept 3, if we can accept that we won't do things perfectly, we want to accept that we will make mistakes when we're having difficult conversations. That's part of our learning, it's part of our moving forward. We don't have to be perfect. We just need to be willing to engage in that space. And the more we're willing to practice, the more we will perfect our practice, as with everything else. How does that precept help us? It helps us to accept our own failings and flaws. So often when we speak to people about conflict, they talk about how they feel less than, they might feel worthless, they might feel that they're unprofessional, that they've not done a good job. The fact that a conflict has arisen may challenge their professional identity or how things went. If they can take time to reflect, turn mistakes from things that weigh them down into opportunities for learning and for growth, that can be hugely helpful in the moment. It can be a hugely helpful thing to model to other people. And also we can apply it to others. People we're in conflict with will not be conducting themselves perfectly either. So we can allow that learning space to extend to others. So we thought we'd end with a few tips, a few key takeaways. When we're thinking about utilizing our capacity to be compassionate in conflict and expanding it in terms of resolving conflict. Firstly, it does take compassion to have the courage to not be afraid to talk about those difficult situations. We know a lot of avoidance can occur in the realms of conflict because most of us dislike it, and that applies particularly to mediators, I think. So to not avoid the people or the issue, hoping that they'll just evaporate and go away, because they very rarely do in our experience. We're wanting to be in the listening space, but really focusing on listening to understand, because it is true that most people want to be heard, and it's that listening that makes a difference. If we can listen from a place that helps somebody show that we're willing to try to understand their perspective and accept their perspective as their truth, even if we see things very differently, that can make a difference. And importantly, people can better hear themselves once they feel that they've been listened to. So even strategically, it's a wise move to listen to other people and then invite them to listen to us. And the words we say matter because they can be triggers to people's reactivity. If we say to somebody there's nothing to worry about, that can land very differently to if we say to them, can you tell me what is it that you worry about? We want to be in that exploratory place rather than that sort of resolving, moving on dismissive place that trying to give premature reassurance can feel like. And again, words matter to ourselves and to the other person and those around us. If I'm thinking a particular parent or patient is difficult, that will colour my whole physiognomy and my psychology and the way I engage with them. I think of the situation as difficult. It's gentler, it's softer, it's more connected, and I'm much more willing to be curious about what's going on with them and try and solve the situation together from that more compassionate space. As Gaynor said, it's a constant attempt to try to put ourselves in the other person's shoes. Even if we have not experienced what they have or would never have, we can try and explore how are they seeing things. What from the life and the person they are, how could this all be landing for them? The willingness to try to put ourselves in people's shoes is a very powerful tool, and again, helps us as well as helping them. And when we apologize, I mean, we've moved on from a time when apologizing was frowned upon. Now we tend to say apologize relatively freely, but we can think about how we do so. If we can be specific and clear, that can help the apology land much more clearly. I'm sorry that what's happened has made you feel X, Y, and Z. That clarity really helps. So to conclude, this is a space where we use the phrase explore before you explain. Explore what's going on, explore the impact when you're engaging in conflict. And if at all possible, just check in with yourself so that you're trying to speak like a human being rather than speaking like an institution. So Oscar, I hope, has got some questions for you. We'll leave this summary slide up, which just sums up the key tenets. Unfolding process, it's often horrible before it gets easier when we feel connected. It helps both parties, and it's a key and important mindset when we're trying to resolve conflict. Thanks very much. Oscar, I'm going to stop sharing the slide so you can ask any questions that may have come up.
Fantastic. Thank you very much, Essie, and thank you very much, Gaynor. There have been some questions coming in. Please do also put them if you'd like to ask further questions in the question box. And a few folks that look like they're for you, Essie, and a few for Gaynor. So why don't we take one that looks like it's for you, Essie. This presentation from Dr. Menson is really insightful and useful. Is compassion taught in medical schools? I suspect this webinar is preaching to the converted, as we've chosen to sign up to it. Those of us who've recognised the power of compassion in care and in conflict will be watching and nodding. How do we share the importance of this stuff with those who see it as a fluffy and soft approach?
Absolutely. I think the fluffiness and the soft skills title of this sort of work is given, I think, is beginning to evaporate. We have kind of young colleagues who are at medical school who tell us that they are starting to introduce aspects on compassion often in communication and skills training at medical schools. But I think the reason we hope you are here is to think about how you can encourage this sort of training in medical schools, in our cake clubs that happen on the wards, at grand rounds. So wherever you are situated, in a hospital, in a GP setting, if we're willing to bring up the importance of these topics, then it's more likely that those in charge of medical education will engage with that. Invite people to explore the compassion and conflict resolution training that's available from various spheres and introduce that from medical school all the way up to consultants. We often have clinical directors who say things to us like, why am I just learning this now? So absolutely, please feel free to advertise the benefits of compassion, both in clinical practice and in conflict resolution. And there's an increasing body of literature to support you.
Thanks, Essie. I would also, an appropriate time for a plug for the courses that we run. We've got two in September and 2 in November on managing conflict with both colleagues and patients, 2 different courses. So sign up to those as well. Another question for you, Essie, I think here. Does this approach apply when the person is frankly racist, misogynist, abusive? Can staff be compassionate when on the receiving end of that kind of thing?
Thank you very much for that question, a powerful question. I hope it may be born out of personal experience. I've certainly had personal experiences myself. The phrase that I would start with is that the phrase that we are the first recipients of our compassion. So I, as many people, have been at the receiving end of directly misogynistic or racist comment. And if I can take a deep breath, ground myself, get into that compassionate space, then it affects me less. So it helps me endure that. It also helps me try and engage with that person in a different way. If I can find my way to being curious, what's beneath that? What is it that's made that person say that? How can I connect with them rather than react against them? Then I know cognitively that I've got more of a chance of moving forward with them. Sometimes I can do it, other times I can't, which is, I guess, where the third precept comes into play. We're doing the best we can. We won't always be perfect, and we can use it as a learning experience. I wanted to add before I finish the question, that it's really important that people take away the message that being compassionate is not the same as being a doormat or being abused verbally or otherwise. It doesn't mean you have to tolerate unacceptable behavior or things that you feel are wrong. But if we can engage with that person in a compassionate way, express our perspective and tell them what we're going to do about it, it's much more likely to land in a way that can be heard. And it's actually much more disarming if we can engage compassionately than if we succumb to the emotions that those sorts of behaviors can very easily and understandably engender in us.
I see one final one for you before we throw on to Gaynor. Someone's saying, I work in a child weight management clinic. A lot of families have had very negative experiences in the past. How can we encourage compassion for patients that in the past have often been blamed for this disease?
Brilliant, thank you. I think that's a really important question. And one of the words that often run through my mind alongside compassion is that importance of acknowledgement. I think in all the work I've done, training to be a mediator and training to be a trainer and a facilitator, the power of acknowledgement never ceases to amaze me. So acknowledging to people that they may have had difficult experiences in the past is remarkably powerful. Starting the conversations with, what have you experienced before? It sounds like it might have been really hard for you. I'm wondering whether we can talk about doing things differently. Acknowledging people's past experiences is hugely powerful, allowing them to tell you a little bit of their story and listening in a way that shows a willingness to understand them can be an absolute game changer. And we in the Medical Mediation Foundation have seen sort of bears turned into kind of metaphorical puppy dogs just by being listened to. Quite often the behaviors people demonstrate are the opposite of what lies beneath, and that can come out if somebody's come to a clinic where they've had dreadful experiences. They might come quite armored up, and when they're listened to and acknowledged, then they can be willing to soften, to engage, and they can often be incredibly grateful for someone who appreciates what they've been through.
Thank you, Essie. And one I think possibly for Gaynor, but you might want to come into, there are a few questions coming in on the same theme here, which is that of time. So for example, how do we incorporate compassion with very little time in our working life, shift work, lack of face-to-face meetings with colleagues, etc.? Gaynor, I'm not sure whether you want to come in on that one.
Yes, well, I think that's a common theme to all of us, isn't it? And I think sometimes listening doesn't take more time than trying to get to the nub of a problem. And I think that's what we try to do a lot of the time. But certainly in my own practice, when I am on a advice line call, for example, helping the doctor who is trying to explain to me something, and listening to them is much quicker and much better and more rewarding for them if I listen to them and ask open questions rather than if I say, yes, I understand that's the case, but we're going to do this, or can you do this, or how do you feel about doing this? It's not a question of listening takes longer, being compassionate takes longer. It's a question of incorporating it into your practice. And if there is conflict, actually, that conflict is going to take an enormous amount of time, and much more time than it would be to try and get it so that there's no conflict in the first place.
Thanks, Gaynor. There's another one here for you, which I think, harking back to your presentation, overwork is leading to emotional exhaustion and declining empathy. How can staff seek help if they experience symptoms like this? What kind of help can they hope to receive that will make a difference?
I think that sometimes taking yourself out of the environment that you're in can help you, and asking directly for help from your colleagues can assist. I mean, sometimes those relationships are fractured, and I can't give a sort of panacea, but I do think speaking out is the first thing that everyone needs to do, and you can always ring us if you're looking for specific ways to be helped. But I think that exploring and explaining what's going on and acknowledging the difficulties are helpful, because people don't know if you're sitting there going through hundreds and hundreds of consultations that you are feeling stressed if you don't tell them.
Thank you very much, Gaynor. Question here, I suppose to you, Gaynor, as well. At what level and in what form can the MDU help in conflict resolution?
It depends what it is. If it's patient conflict, we do help hugely with complaints, and we can help with meetings, and we can help with discussing and debriefing as to what's going on. Sometimes it helps just for us, for example, to listen to the calls that have been had and give our opinion. It's very interesting that sometimes the opinion of somebody completely objective and not involved can be slightly different to those who are involved, and we can tweak out particular ways of dealing with patients. We can help if patients are abusive, for strategies as to what you do with that, and with colleague conflicts, we have courses, and although conflicts which involve conduct are not patient-related medico-legal questions, and we can certainly signpost if there are queries. But every query is individual, and I would encourage every MDU member who is listening here to contact us on the advice line if you've got any queries or concerns, and we can look into those with you.
Thank you, Gaynor. At the Medical Mediation Foundation, what we try and do is equip clinicians with the skills we use as mediators to use in their day-to-day working lives. So if you're interested in this kind of content, please do have a look at the MDU courses that SE and I run. The Managing Conflict with Colleagues courses, which is SE and I, are on the 14th of September and 3rd of November. And the Managing Conflict with Patients courses, which is me and Sarah Barkley, 23rd of September and 8th of November.
We do have some seminars as well, and some online courses that we do. I see we did have a slide. Could you put that up?
I'll just share that for you.
So we can arrange for our colleagues to come and see you in your workplace and deliver seminars, and we can also help you to source the online courses that we have. So there we are. There they all are for you. But if you're interested in this particularly, we do have much more in-depth courses on managing conflict between doctors and patients, and also conflict with colleagues if you wish to join us then.
Thank you. Just to say thank you very much, everybody who's asked questions, made comments, really appreciate those. Thank you very much to Dr. Gaynor Whiter and Dr. Essie Benson for your excellent talks. And the clock has struck 2. Thank you very much for coming, and see you at the next one.
Thank you.